MIS doesn't mean pinhole, stab wound. MIS means minimally invasive of soft tissue. You want to touch the bone. You want to preserve the soft tissue. So a lot of people think it's a lot of percutaneous work. What is the advantage? Because pelvis has been thought to be extensile exposures. If you go to leg toenail, they will have a big exposure. There's bleeding, and of course, if you are a good surgeon, patient is alive. If you are a bad surgeon, the patient bleed to death. Secondly is that if you disturb the soft tissue less, you will have a faster recovery with less damage to nerve, muscle, and more important, the veins and arteries of the system. Now you have cannulated screws, so you can put guide wire and cannulated screws in certain areas of the pelvis. Blood loss can be reduced. Of course, if you hit the wrong place, you can bleed more because you didn't see it. And now, because we have a better understanding, you have done a cadaveric, it is very different from looking at a textbook photograph. What are the disadvantages? Number one is, of course, learning. All of us never start in general surgery or in orthopedics, never learn about MIS approach. We learn a standard approach. We use Hoppenfeld, we use all those anatomical surgical books. So now you require very accurate knowledge. So the cadaveric has given you a lot of idea. The orientation, the plane, the layers are important. You need to have good imaging because the imaging is translated to your bony pelvis. The bony pelvis is kept in your operating room, and then the mind remembers what you need to do, where you place the screw. You can do preoperative planning by computer or by tracing paper. So you can actually start to mark where my screw is, what direction, and you can more or less rehearse your surgery. Imaging. I think you have no problem with imaging. We see very good C-arms. I'm sure you can get better ones as well. We even have a 3D fluoroscopy in our system. O-arm and Siemens has a 3D fluoro, where we want to be even more particular. When we put the screw, we want to make sure the screw stays exactly where we want. We do a 3D fluoro after the operation. And of course, you must learn the indirect reduction, because you are not going to have direct approaches and direct reduction all the time, although there are tricks about that, which I will show you. And some people are doing computer navigation, putting wands and doing iliosacral screws. It's fancy, but the minority of people have it. So let's look at screw points. Now the first part of the MIS is about leg screw in the pelvis. You can do this open or minimally, it doesn't matter. But as long as you know where to put your screw. Okay, so the first screw you must learn is the superior rami screw. So that is given starting at a point below your I'm trying to get it, yeah. Okay, below, you see the starting point below this, not at the point there, below. And then you are missing the acetabulum there. Eyelet crest screws are very easy to put in. You should get a good reduction with them. You can put them in small, because of the curve, you can't cover the whole eyelet crest with single screw. Then you can do this. This is the same direction you put for your low external fixator pin, which is the same place, the same direction, and just the longer screw thread. And you can fix anterior column fractures like this. Just anterior column fracture like this. You can be fixed with these 3 screws. Transacetabular screw requires a bit more skill, but with your finger in the pelvis and the obturator foramen, you can actually make a small incision and put in a transacetabular screw. Pubic rami screw, as I show you, is the first thing you learn. And then you can do it with or without posterior fixation, depending on the situation. What are the principles? You supplement usually a posterior reduction, and because you have a rami fracture, it is a bony fracture. This is a very lateral rami fracture. So in order to put a plate, you have to go almost from here all the way to the back, because you cannot place any screws here. So you're doing a full ilioinguinal approach. So why do it when you can do a minimally invasive? So you already learned about the outlet oblique view, which I don't have to tell you. And then you can do the view that you see here. Maybe we could have tried it just now. One of the things that we could have tried, we can show you how to see outlet oblique view with a screw this way. If you your starting point is always below the pubic tubercle. So this is a picture you see on the C-arm. okay, outlet oblique view, and you can pass a screw and a drill bit. And I don't like to use cannulated, like I told you. These small screws, the cannulated wire is very soft. It can go into areas you don't want to go to. Once you make the hole, is the end. So I always use drill bit. Okay, and the hip motion at the end, when you put the depth gauge to measure, move the hip, and you will see the depth gauge moving. The depth gauge is in the hip joint. And post-op CT we do to make sure we are not in the hip joint. What are the indications? The indications are usually minimally displaced fractures. So you need a minimal, you don't have to do a big operation. In the pelvic ring, the Dene type 1 iliosacral screws are quite common. Okay, sacroiliac dislocations, they are life-saving, and I will cover the acetabulum in the second part. So this is a case courtesy of Peter Regazzoni, and this is, 13 years ago they were showing this. We have a sacroiliac type 2 Dene fracture, and then you can reduce it with maneuvers, and you can use external fixators. And after reduction, you put a screw through the SI joint. This was done just two incision like this. So you also did it today. So 15 years ago and today, I'm sure the technique has remained largely the same. You can do a partial ring closure. It's an open book case, but the rami is fractured. So you do your inlet-outlet view, damage control with a C-clamp here. And then after that, you convert into an external fixator. You can see that the pins are right inside the two tables of the iliac wing. And then you do your CT to see where what is the direction, anatomy, orientation, etc. And then you do your iliosacral screw. In this case, you can see one of them bypass. The screws tend to get a bit interlocked. So you can put 2 screws on each side, trying to go across the midline. And if you do one right across the midline too far, like this one, you will see that the other one you tend to block. So you may have to use a shorter screw on one. Okay, and this is your lateral view with the external fixator still in place. And this one is one where you have a fracture in the front, an open diastasis with a rami fracture. And then we just fix it with the back with SI screws and also with the pubic rami screws. And this patient was sitting out of bed early. We didn't walk her because she was quite obese and had a bit of head injury. So beware in iliosacral screws the transforaminal fracture, because in transforaminal fracture, they often comminution. And then when you use this very powerful screw, you tend to compress. You can get sacral root stenosis late. So be careful of them. For any fracture entering the neural canal, I tend to go to the back. I have to decompress, laminectomy, sacral laminectomy, and then you can put a screw or a plate, which I do from the back. And if you cannot reduce, don't try, okay? It's better for you to do an anterior ala plating than to get into trouble if you don't have a reduced fracture at the SI joint trying to do percutaneous, because the anatomy has changed. It's not the normal anatomy anymore. So when in doubt, do post-op CT scan. This is one, actually my own case. You can see the bleed from the perisacral plexus. Can you see that? Okay, this is a CT contrast because the patient was losing hemoglobin, and then we found that the screw was actually exited the sacrum. So this is my own case. Okay, this is a submuscular plating, can be done. I will try to show you some ilioinguinal approaches. So here is a pubic ramus bilateral, like a butterfly type H-shaped fracture, sacroiliac fracture, ala fracture. Young lady, very small size, fell off the motorcycle in Jakarta, was evacuated to us with a hemodynamically stable, and then we just did a MIS fixation. And you can see that we have to bypass the ring. So this one is too close. Sorry, here is a bit too close for iliosacral, for pubic rami screw. This one is okay, so we decided to pass the plate. So you can see that this is a smiling type plate. SI joint behind has been fixed screw. And this is the only incision we use. Just a 3 incision, lateral window and the medial window fan and steel. And then you can just tunnel the plate under the psoas. Don't have to touch, don't have to see the neurovascular bundle. For acetabular fractures, usually no comminution, minimally displaced, totally reducible as we did for the SI joint. No third fragment, the hip joint, the head is okay. Anterior columns lend the best type of pattern because you just have to go from front to back, and you should be able to secure anterior columns. Low transverse or T-types that are well reduced can also be done. There are 3 types of screws. Within the column, you can place a screw. Between columns, you can place a screw. And then you can submuscular plate. So I'll just show you 3 examples. So if this is the acetabulum, I told you already where you can place the screws to be an interfragmentary screw. In other words, between columns, okay? Intercolumns or between column. So you just have to close a triangle and you get a case like this. This is done just percutaneous fixation of a transverse fracture. This patient, again, another one, you can see that this is transverse fracture displaced. You can see the double shadow. The head is not inside the acetabulum, so it's medially displaced, and some comminution. And then because he had a problem with the bleeding, so we put him on traction. And then he had to put an IVC filter because of a DVT. Sorry, not bleeding, DVT. So we put IVC filter and we went in later. But at that point of time, after traction, we found it is such a surprising reduction of the fracture site, and we had to wait about 10 days or 12 days. So we didn't want to openly manipulate because it would have been an ileoinguinal with a spring plate or something like that. So, and then we started him on pin jack traction, and then we put him on same ilosacral, percutaneous screw fixation. Not 100% reduced, but it does save him from a lot of blood loss. And 6 months later, everything has united, the screws, and none of them are broken. But these screws are 4.5 screws. They are not 3.5 screws. So I think you will see a lot. My plates are all 4.5 plates. Okay, so we get a good views, and you can see the union, and the hip is moving well. Anterior column fractures, again, this is very clearly anterior column into the joint, exit in the front, and these are just the CT scans. And we did an ilofemoral approach, and just by some screws, we can get that fixation by anterior column fixation. So again, it's just a matter of study of the anatomy, your good preoperative imaging, and then you are ready to go. There is always a possibility that you have to do an open reduction. Just extend the incision. Don't be a proud person and say, oh, I must do it percutaneous. If I get a patient into trouble, it's not very good. What about acetabular fractures with limited invasive approach? Okay, what I call it is submuscular plate. Just like you call for the femur, the shaft of femur, a submuscular plating rather than a MIPO plating. So this is quite a large fella, car passenger, a heavy fracture. And what we had was a transverse T-type. So we had a fixation. And what we did was we tried to do a circumferential wire. Okay, so ilofemoral and a so-called stoppa or ilo-anterior type of infusion. So I want to go down here for my wire. So we place a circlage wire through the anterior inferior spine with a wire passer, the spring plate, and the spring plate with wire, and then a neutralization plate. And the reduction, we always do post-op CT, okay, the reduction of the joint in 3 planes, 3 views, all reduced. And you can see the incision is a separate incision. So again, no devascularization, no tapes around the neurovascular bundle, reduce the risk of DVT, etc. And also, you spend less time in the operation. What is the take-home message is that you must, of course, as we have learned today, know your anatomy. Just the orientation of the pelvis on the table, your finger in the finger in the place that you want to feel, it should be where you are. The plane of the fracture, the plane of the plate, direction of the screw. All this is part and parcel of learning open reduction as well as minimally invasive. Okay, pubic rami, symphysis, if you want to try those butterfly fractures, they are the best to try if you want to try the screw fixation. And again, another anterior open fracture, but we put in some gentamicin bead and we just put some screws because we didn't want heavy plates in that area. And then the patient united quite nicely without any complication. So screws are simple, okay? They are easy to use. I don't, as you know, don't hardly use cannulated screws, so you don't really need it. I use a good drill bit. So I propose that you always use 3.2, 4.5, but If you don't have them, then 2.5, 3.5, that's fine. So there are very few textbooks. But if you have to buy a textbook, please.